particular one. Okay, the next section deals with an update or review of the Medicaid reform matrix. And just to set the table a little bit, many of you are aware, and some of our new attendees today may be not as aware, that embedded within our budget, we concluded this past year, which created this commission, was a decision that we could expand Medicaid based on the decision of this commission if a certain reforms were accomplished. And we set out a series of reforms which were aimed at cost control, integrity of programs, the overall quality of the program, because many people were concerned about expanding a program that many considered a broken system. Now, that's a debatable point, but obviously there are things that we wanted to address before we potentially expanded it. So that's what we have here within this matrix, and Dr. Hazel is going to give us an update on where we are with the matrix that he and his staff have put together to kind of keep us track of where they've been and where they're headed. So, okay.
Thank you, Senator. I'm going to start with, again, just a little review of where we are. Some of this Dr. Smith covered, so I won't hit in great detail, but remember, every state is a little different. In Virginia, we have a combination of fee-for-service, say around long-term care waivers that's listed there, but the majority of our acute health care is contracted through managed care organizations. There are some services MCOs do not provide, but Medicaid provides them through carve-out services. We began with this managed care program, I'm using we rather loosely, but 1996, and the numbers there today, I think, are known to you. We currently have 6 managed care plans that are participating in Medicaid. There is pretty good coverage around the state for managed care and individuals. And the vast majority of areas actually do have choice of plans. The value of managed care and why we have used this and why we recommend sticking with it is really these 8 points. The top 4 really have to do with the patient care, be it board-certified networks. We have more care management, there's NCQA accreditation and ranking. There's some predictive modeling and chronic care management that comes with managed care plans that one does not get under fee-for-service. From a budget standpoint, plans are a more sophisticated purchaser typically than a state is. They provide budget certainty because we capitate. Most of these plans actually do have their offices in the Commonwealth, and there are some jobs, and we are able to ensure that their plans are solvent and stable without excess profits. Now, the criticisms, when we talk about the reform, we are responding to a series of criticisms in part, and I want to address those criticisms. And first is the